and lubricate the tip. So I'm just giving you things that aren't written in there. Okay. Now, if you look at some tips on the pink packet and you pull out your other white packet that talks about administering medications through an NG tube, it's on the front page. It looks like this. This is thebomb.com. So you can put that up, sleepyhead, and find this. It's up under your CPR. Okay? All right. What I wrote on here is emphasized completely in here. And obviously, after we do this page, it's lunchtime. So hang in there a little bit longer with your sleepy, hungry selves. Now, if you look at what I wrote on the pink, you can see I wrote some highlights. I wrote, give one medication at a time, crushed with 30 cc's of water. And I put C handout. Then I put don't crush, enteric sustain, blah, blah, blah. And then I put number one complication of a feeding tube is aspiration. To avoid aspiration, I put aspirate gastric contents, check the pH. So I wrote a lot of things we're going to go over now. But I love this because it gave you a drag and drop order. So let's do it. It says how to give medication through feeding tubes. Instructions. Number one is essentially saying, I'm on the white packet now. I'm literally reading from your white packet. It literally says, make sure the prescription is complete. If I translate that, that means check the order. Doesn't it? Okay, check the order. The paragraph under it is huge. Very big deal. It already says, the first thing you do is make sure the orders is okay. Okay, yeah. Then it says, if a reaction could occur, stop the feeding 1 to 2 hours before you give the medicine, then wait the same amount of time before you resume the feeding. Let me tell you why that's there. Your patient has medications that need to be taken on an empty stomach. This is there for that purpose. When I give PPIs, Synthroid, and yes, I am making you a list right now. When I give PPIs, Synthroid, Dilantin, TB medications, biphosphonates, so biphosphonates, just to remind you, they all end in dronate, and examples of them include Actonel, Boniva, Fosamax, so those are all medications that have to be given on an empty stomach. That's why number one is there, because you better stop that tube feeding an hour before. Okay. Next is determine if the medications need to be crushed. Let me give you some shit not to crush. Some shit cannot be crushed. And I want to make sure you see the first line in that next sentence. It says it's best to give the medications in a liquid form. Okay, nurses, this is you. You are trying to make sure your docs and your nurse practitioners order stuff in a liquid form, because some things cannot be crushed. Never crush Protonics. Never crush Depakote. Don't crush Protonics. Don't crush Depakote. Now, Other medications you can't crush is in the next sentence. You're not about to crush nothing that says enteric coated, which is a lot of aspirins. You're not going to crush no buccal nothing, no sublingual this and that. And here's some tips. When medications say Detrol XR, Wellbutrin XR, CR, XL, CL, whatever. All these little ABCs after the medication. I call it alphabet soup. If they got little ABCs after the medicine, you ain't crushing it. Because them little letters after the medicine mean controlled release, extend release. You're not about to do it like that. You can't crush those. No, 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 no. Okay. Number 3, liquefy the medication. Once you are at the bedside and you've introduced yourself and you check their 2 identifiers and explain what you're about to do, you have to liquefy each medication. Please highlight 30 cc's of water separately. 30 cc's of water. You're in the wrong one. It's the one that looks like that. 30 cc's of water separately. Now, let me be real with you, because I know you're looking at me like I'm crazy. Here's how it goes. Patient is on 47 damn meds. That's real. That's what my patient was on, 47 damn meds. And I got to be honest with you. I just got my first job. My guy has 47 meds, and they're on an NG. I'm going to lose that first job if I crush and liquefy and push one at a time, because I'm going to be in that room for 2 days. That's real. But if I have one patient with 1 NG on 4 meds, I'm doing it the right way. It's done the right way for a reason, because these tubes can become occluded very easily. So you pushing and shoving shit all at once is one of the reasons why so many tubes become occluded. But reality for you and me as the real nurses in the field is I ain't got but 12 hours, not 12 days. And if one of your patients got chaos, all them damn meds, you're going to have to kind of split them up a little bit, but you cannot do one at a time or you're never going to get out of the freaking room. And you're going to get fired and you're going to, oh, I did my job the right way. Well, you did, but you kind of didn't think of reality, okay? That's why the new nurse is so upset, because it's just not matching what you learned, okay? But if I only have a couple patients with an NG and they only have a few meds, I'm going to do it the right way. I'm always going to do things the right way. Whenever it makes sense, I'm doing it the right way, okay? So the reason why you're doing this is because a damn tube can be so occluded easily. And I don't do, by the way, I don't do 15. I do 30. I need to keep shit liquid. I just do 30. Keep it moving, okay? Now, number 4. I cannot tell you how much this is so important to put stars all around. It's the most important one out of all the steps. Before you give medication through this nasogastric tube, you need to check placement. And don't you let me hear you out there blowing air, checking for swish. What kind of crap is that? That is not ever supposed to be done. You are supposed to be checking it by aspirating gastric contents and doing a litmus test. What the hell is a litmus test? A pH. I already know. I already know, honey. But you better believe this. I ain't never did a swish in my life. And I had 2 people, one in here standing up here. I don't know if you guys were here. You probably were. She stood here and told you how her mother almost died because the bimbo did the swish with her mother's NG. Her name is, what's that baby's name? Courtney. She sat by Nick at this table. Little Courtney. And her mother was in a car accident. She takes care of her freaking mother. She's long-term care. She's never going to get out of this place. She had a stroke and everything. Her mom spent 30 fucking days in the hospital because of a swish nurse. They never checked the pH, nor could they have ever checked the pH, because guess what had happened? Her fucking NG had perforated her duodenum. Well, if you bothered to check the pH, you would have known that the duodenum has a different pH than the stomach. The pH of the stomach is acid. The pH of your duodenum is alkaline. The pH of your lungs is alkaline. It's so fucking easy to check the pH. You're never going to get this wrong. You're never going to blow this. Do what I tell you, because her mother almost died because you didn't. The other girl, her damn daddy died. She didn't know why till she got in here. She said, I was sitting right there. I'm in nursing school. I watched her do the swish. I thought that was the right thing to do. Then my dad started coughing violently. Well, the fucking tube was in his lungs. Your swish didn't work. You need to check the pH. Why else is it there? This is real. Now, so you're not going to blow this. You're not going to blow it off. You're going to see all kind of shit with the nurses around you, but you're not going to be one of those nurses ever. You're so much more cut above. Okay? Now, look what it says next. And yes, you do care that it says it next. It has a big, huge next check for gastric residual. If you ask all the nurses in this room, because y'all going to see it, because y'all in here and they not, how do you prevent aspiration? You know what they're going to tell you? Check the residual. No, the fuck you don't. You check that pH. That's how you prevent aspiration. I already wrote it on your pink sheet. You know I got you. I wrote it as big as life. On the pink, I wrote aspirate gastric contents, check the pH. It's only after you do that that you check the residual. That's why the word next is written there. It's not first, it says next. Okay? So be very, very, very astute on this one. Okay? Now, then it says you can give your meds. Let's put a little note to self on number 4. Let's just play it all the way out, babies, because it's important. I actually did help you with this on the pink part. So if you go back to your pink where it says aspirate gastric contents, check the pH, I put check residual every what? 4 hours if continuous, and right before a bolus, transfusion, hold if greater than what? It used to be 100. It's 200 now. You got to know when it changes. In other words, if you go by what you were taught, you probably were taught 100. Your doctor's not going to like you very well if you don't know the newest thing. So you're not calling them for a residual greater than 100. It's got to be greater than 200. And guess how we do this? Look what I wrote. I tried to help the babies out. That's why y'all carry this with y'all at work, because it's the hookup. Here it says, push it back in, give Reglan as ordered. That's what we do now. We do different things now. Give Reglan IV, wait for an hour, recheck. If there's no change and you still got 200 cc's, then we can go ahead and call the doc and get an order for KUB or whatever. Okay? So that's very different than what you may have been taught. Okay? Now, but you better know that for this exam. You better know that. What is the action of Reglan? Think about it in relationship to what I just read you. What is the action of Reglan? What does it do? We're always going to empty our gastric, so what does it do? You think it slows it down? Would that work for this patient? They got a residual. Do I want to slow this down? There you go. You have to think. You have to think about it. If my patient still has a residual, don't I want that to go bye-bye? Don't I want that out of the stomach? So I gave Reglan to speed up gastric emptying. See? That's why you have to understand the action of drugs. Now, of course, Reglan ain't on your test. So what is, nurses? Oh, shit. There go my baby. Metoclopramide is on the test all day long. This is Reglan. As you know, there are no brand names on this exam, not one. It's all generics, okay? All right, baby, so you good. We got it done. It's over. Now, there's one more little thing here. It says, give the medicine, use a syringe, drop the medication, highlight it. Give them one after another. Now, here's what I tell you to do. I wrote it in big letters at the bottom. I do a crush, push, flush routine. Crush the med, push the med, flush after every med. After you're all done, and by the way, I don't use 30. Look at the next page. After you're done, if you look at the next page, I don't do 30 cc's of water. Y'all see it? How much do you think I do? Knowing that I'm very neurotic. 60, yep. It ain't but one sentence on that next page. But trust and believe it's an important sentence. If you only knew how fast NG tubes become occluded, you will listen to your girl. Because when you got an NG tube and it's occluded, your whole shift just got yucky. Because number one, and I don't think you get this, but I'm going to help you understand it. One of the worst feelings on earth is to have an NG inserted in your freaking nose. It is the worst procedure. At least with an IV, it's quick and dirty done. This NG is going to irritate and drive you crazy. And I've had people say the worst experience they've ever had was an NG. When it's occluded, how easy is it to become occluded? You got an experienced nurse here. Two big things. If you go to your central lines on your pink packet, and that would be, I don't know, page 2, 3. Okay. I wanted to stress with removal. And this is the nurse taking out the actual central line. Sadie came in and did a nice little lecture, kind of like an hour spiel on chest tubes, central lines, all the things that as a nurse she wished somebody had told her. And it's interesting because it does help you to know this. When the nurse pulls the central line, Sadie said, remember, it's really long, and people don't really think that through. It's super duper long. So your patient has got to do a practice run before you pull it out, because your patient has to bear down the whole time you're pulling it out. And you can't just like yank it. You've got to gradually pull it out. And so she does this practice run with her patient, which I think is a really good idea. And she says, okay, let's practice together. Okay, 1, 2, 3. I'm going to pull it out now. Start bearing down. And the patient starts, hold, 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 hold. Because if they inhale, they just got an air embolism. Hold, hold, a little longer, almost done. Come on, practice that with the patient. Okay, so central line removal, very big time for air embolism. Patients got to bear down, hold their breath the whole time you're pulling it out. Afterwards, you get a Vaseline occlusive dressing or a Tegaderm occlusive dressing. Now, she said what nobody told her until she really got in it is this is how that whole dressing thing works. You've got the occlusive dressing in your hand, and as soon as it comes out, you put it on. Nobody needs air to get in there. So you pull, 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 dressing. Okay? What, the dressing?
No,
Oh, yes, and you examine it, and then you cut the tip off and send it if there's an infection. So if your patient has a fever, the tip of it got to go for culture. Yep. So examine it for intactness. Examine to make sure it's intact. If there's any question of an infection, cut the tip, send it for culture. Okay, so that was central line. Up here, you can see it says NG for gastric decompression. We did NG tube feeding, medication administration. Quick word about this. This is not this on your exam. What does it say about this on the exam? How do they spell it out? What do those letters stand for? Does anybody know? Because if you're normal, you don't. I would know. I just called it PEG all my life. But this is what's on your test. Percutaneous endoscopic gastrostomy. How about that? Is that a mouthful for the babies? So basically, that's your PEG. Percutaneous, and this I would write on your white pack, the one that has the NG tube on the front. I wrote it in the middle, like where the spaces are at the top. Because keep all your little tube feeding stuff on one page. So I wrote PEG. I spelled out the PEG. Spelled it all the way out. Okay. Now, I want to make sure you understand this, and you made me think of it, so thanks, Dana. You said it was cutting this shit. So she made me think of it, that nurses don't necessarily understand, obviously, cutting it, the significance of this tube. This tube is placed surgically. This is not simple stuff here. This tube here is placed under conscious sedation. So your patient had to get versed, and we have to place it under endoscopy. It takes 4 to 6 weeks before you can use it. So it is not fully established for a few weeks. So up to 4 to 6 weeks before you can say it's secure, stable, not going to come out, not a big deal, go for it, okay? Like seriously, that's a big deal. You got assholes cutting it. Imagine, okay? So the other thing I wanted to tell you about this, if it becomes dislodged in the first 7 days, sort of like a trach would become dislodged in the first 7 days, you do not reinsert this. It's got to be replaced through endoscopy. So if it becomes dislodged, it's got to be replaced through an endoscopy. You must flush before and after every bolus. And you need to flush every 3 to 4 hours in between continuous feedings. I'm going to say that again. You have to flush before and after every bolus and every 3 to 4 hours during a continuous feeding. Last thing to write on their white packet, J-tube. By the word itself, J, tube. What I want you to remember, you got to know your anatomy. This is that jejunum. So we're not in the stomach, are we? We're in the small intestine. This is a jejunostomy. Jejunostomy is a J-tube. You will have a separate port coming off of it for meds. Do not screw that up on your patient. There's a separate port coming off of the PEG tube for medication administration. Huge, huge, huge caution. One of my delightful babies who remembers me slapping you upside your head in my passionate way, telling you, don't you dare put an NG tube feeding in a TBI patient without that CAT scan or MRI telling you what's going on. He remembered me saying that. So when he found out that the nurse had inserted the NG tube into a TBI patient and it coiled in the freaking brain of that patient, he made sure he Facebooked me. This is what you better know. I told you this in endocrine. I told you, if you take your little bitty finger and you put it in your nose, which you cannot do it, but if you could, and you keep going, what are you going to hit? Pituitary. That's what happens with the TBI, a traumatic brain injury. You put that injury in, it's going to keep on going to the brain. Because you have a fractured skull. You have an injury. And now you have a freaking NG coiled. I will never forget the CAT scan picture. It's a coiled NG. If you Google image, you'll see it. Because it's not the first time the nurse has done that. Google image. What you have to put in your notes, TBIs get an oral gastric tube instead. Not nasal, oral. OG we call it. OG, I'm sorry, I don't know where that came from. OG tube. I don't know. Okay, so that's that. Okay.
So how did she know it was right?
She didn't know. She was supposed to not put one in a TBI. It's too much. You're doing too much. And the order is not going to say that. It's going to say NG tube per order for gastric decompression. Because, head injuries get gastric decompression. Takes you to think. TBI? Where's the CAT scan? Where's the MRI? Has the doctor read it? And the doctor hadn't read it.
Wouldn't that, raise the ICP?
Well, how about we kill the patient when we put NG tube feedings in their brain? ICP is the last we have to worry about. How about we killed the patient when we put an NG in their fucking brain?
No, I'm not.
This is non-sterile. This is sterile. Screw ICP. You got a bigger problem. You killed the patient. You killed the patient. It's not an issue of ICP. It's an issue of dumbness.
No, what I was asking was when you normally put it's not supposed to go in your brain. It's not supposed to go.
It does if it's a TBI and there's a hole in there somewhere from the traumatic brain injury. If it's an MRI, CAT scan has been read by the doctor, and this is okay, and it had not.
Okay. So you could just bypass all that by just putting an OG down inside.
A lot of people do. They just can't stand how many people have had traumatic outcomes, and they don't even write for an NG anymore. Whole lot of people. But your resident started in July, and this is July 2nd. Think that way. Julys are awful. Your resident doesn't know anything in July. He just started. He's going to write NG for gastric decompression, because that's what we do on all brain injuries. We do gastric decompression. Don't get it twisted. We still got to do it. We just don't need to go through the nose. Now, that's my next point. Gastric decompression. If you look at the pink, you can see I have a whole section on it. And it's intermittent suction. And I want to emphasize it's gentle. You're not sucking the membrane off the stomach, okay? Please. Why is your suction up to 2,000? Just go on and just gentle. Little intermittent, gentle suction. You don't want to go crazy because here's why. You don't want to suck all the acid out, then you throw the patient into alkalosis. So it's gentle, intermittent gastric decompression. Now, it may be called a Miller-Abbott. It may be called a Salem Sump. It could be called a Sankston Blakemore in the case of the esophageal varices patient. It could be that we put in an NG for gastric decompression because we have a poison case in front of us. It could be you have a suicidal drug overdose. It could be you have a GI bleed. I've written a bunch of that stuff already for you. What I do tell you for the lavage is you let out the poison. For the gavage, you get in the ice water. G for get in, G for gavage, L for lavage or let out. Okay, now, so here's the deal. GI bleed comes in, I'm going to do an ice water gavage. Well, why? Because ice water is vasoconstricting. It's going to stop the bleeding. Versus patient who overdosed on, oh God, what of all the things I've seen in my life? Well, a good one for kids used to be, we don't see this much anymore, baby aspirin, because it tastes like little candy. They really did taste like candy. Little bitty orange. Anybody remember that shit? Who old like me? No, none of y'all? Chewables? Thank you, Lou. The cameraman says he remembers the chewable orange baby aspirin. Tastes just like little Smarties. Dana, how the hell you know? Your grandmama still got them? Probably so. Well, they were so good. They were like yummy. I remember eating way more than whatever the dose was. Okay, so if your child eats those, we're going to do a lavage, and what are we going to put down? Activated charcoal. Now, let me just help you out, give you a little holy hookup. If your patient is poisoned, put these steps down. We're going to do a lavage, because you're going to let it out. We're going to do a activated charcoal lavage within an hour of ingestion. So it's got to be right away. Only if the overdose or poison is lethal. We usually do NG, but we can also do OG. It doesn't matter. It's a large bore tube, like a 36 to 42 French. The head of the bed must be up. Suction, intubation, trach set at the bedside. The poison can be so bad coming out of the body as well as when it went in that an oral gastric tube might be preferred for really toxic poisons because it's going to be better coming out of the mouth than through the airway, the nose instead of the nose. Okay. All right. Now, so that's that. Next on the lineup, this. One last thing. Look what I wrote for the pH. What is the pH if I put it in the small intestines? So I don't do a gastric decompression, but I do a Miller-Abbott. If I do a Miller-Abbott, what is that called? What is the pH? Look what I wrote. You see how the pH of the small intestine is really, really high? It's alkaline, right? What's the stomach? Less than 5. It's like 2 to 5, right? So it's less than 5. Do you see how you can't screw this up if you just quickly check a litmus paper? The pH is so different. Now, before I let this go, because I probably should not, what color would it change if it was in the small intestine? What color would it change the litmus paper? Good, good job, blue. Alkaline is blue. Remember that, everyone. Alkaline is blue. Acid is yellowish, kind of orange, yellow, orangey yellow. If it's real acid, it's almost red.